speaker is Dr. Simon Beaven. Simon attended Stanford University and then went on to receive his MD from the University of California at San Francisco. He then went to the Brigham and Women's Hospital and Harvard Medical School in Boston for his residency. Joined us here at UCLA in 2003 for his fellowship in the Division of Digestive Diseases, and then joined the faculty here in 2010. Simon's going to be talking to us about abnormal liver tests and non-alcoholic fatty liver disease.
All righty. Good morning. Thank you for turning out for a talk on fatty liver disease, something I think about all the time, and I want to share a few thoughts with you this morning. I have no disclosures. There are a few FDA-approved medications I will mention, some off-label uses. The objectives are actually quite broad for this talk. I'm going to try and encapsulate for you everything from diagnosis of fatty liver to its natural history, the pathogenesis of the disease at a molecular level, all the way through therapy and management. So, even despite the title, this really isn't a talk about abnormal liver function tests. You probably didn't come all this way just to hear me talk about ASTs, ALTs, etc. But just to review, it all starts with a thorough history and physical. The diagnosis really should be apparent from those two things alone. And then typically you'll find an abnormal level of transaminases. It's always useful, if there's any doubt, to repeat them and to really include what I consider true liver function tests, which are markers of synthetic dysfunction or potentially markers of synthetic dysfunction like the albumin or the clotting time, INR, the renal function, and perhaps the sodium, but also the platelet count, because you probably all know that the falling platelet count is usually the first sign that portal hypertension is developing, and that's usually my first clue. My cutoff, and I think Bruce Runyon would agree with this if he's here, is about 160,000 platelets, not the lower limit of normal that most labs give. Then you're stuck with what's going on once you have abnormal transaminases. And typically what I think about is this an acute process or a chronic one? That's really what you have to answer first. And the absolute degree of elevation is typically a clue, but not always. There are fatty liver patients who have 10 times the upper limit of normal lab tests. There are fatty liver patients who have abnormal bilirubins and alkaline phosphatases, but that's not the typical scheme of things. So dividing abnormal liver function tests into acute and chronic causes, you can see that the acute ones really are related to either infections, I say viral hepatitis here, but it really includes all sorts of infections, and drug-induced liver injury, by far. And that includes xenobiotics, over-the-counters, herbals, you name it. As you know, in the chronic side, the major causes of abnormal liver function tests are the major causes of chronic liver disease: NAFLD, NASH, alcoholic liver disease, and chronic viral hepatitis B and C. Drug-induced liver injury is actually on this list as well. Most people like to jump to autoimmune hepatitis and hemochromatosis and weird genetic stuff, but quite frankly, you need to spend more time thinking about drug-induced liver injury, because essentially any substance that goes into the body can potentially give you an abnormal liver test. Take-home point for you is really the non-hepatic causes of elevated ASTs and ALTs. And this is an area, I think, especially in primary care, where you can do a lot of useful detective work early on. Probably 4 to 5 times a year we see patients with abnormal liver function tests who you screen them for viral hepatitis, you talk about alcohol, they're not obese, and yet they have abnormal liver tests, and they turn out to have celiac disease. So you have to be aware that celiac disease is a major cause of an elevated AST-ALT. As are endocrine disorders, more severe things like myocardial infarctions. Many of you may remember we used to use ASTs and ALTs to diagnose a myocardial infarction. And then the last two I think are particularly important. I see a whole host of young, healthy, and it's typically men, had a couple women, who live at GNC. They take these supplements, many of which contain creatine, and they elevate liver function tests. And it's very difficult to convince people to stop taking their muscle-building supplement. But if you can have them do the experiment, it's really quite remarkable. And you can prove very quickly that it's, again, a drug-induced cause. The diagnosis, there's no magic here. You're going to see it on any form of imaging. You may get a biopsy, although that's not required in my view. You really need to suspect it when any of the features of the metabolic syndrome are around, and the typical elevation of the ALT being 2 to 3 times the upper limit of normal. So if it's under 100, but it's above 30, you're probably in that range of classic fatty liver. What's important to do is exclude alcohol and other medications. And of course, this is not a complete list, but these are 4 common ones that cause liver function test abnormalities: steroids, tamoxifen, which actually gives you a fatty liver NASH picture. Amiodarone, although I'm not sure how much that's used anymore, and heart therapy for HIV. Anything that interrupts the enterohepatic circulation, either surgically, by gastric bypass, from starvation, or the use of TPN, can give you abnormal liver tests. And then if you've ruled all this stuff out and you've got, say, a thin person and you're not sure why they have an enlarged fatty liver, then it's time to think about inborn errors of metabolism. Don't be afraid to send people for referral. I love talking to people about this stuff, and mundane, rare, I want it all. Okay, so the pathogenesis of metabolic syndrome, and the metabolic syndrome is shown here really on the right, this constellation of 5 conditions that are all interrelated. We think the underpinning is insulin resistance, but it's not clear that's the only thing. And I wanted to share with you that in the last decade, the thinking has really turned to the relationship of metabolism and inflammation. So how many people here think that you have to have inflammation to cause insulin resistance to lead to the metabolic syndrome? Nobody's daring. How many people think you can have elevated markers of inflammation and still be insulin sensitive and not have any problem whatsoever related to diabetes? Okay, a few show of hands. So the scientific thinking historically has been you get inflammation from enlarging adipocytes, inflammatory markers go to the liver and cause hepatic insulin resistance. But I will tell you, metabolism does trump inflammation, and there are lots of examples where it's the metabolic effects, and the inflammatory stuff is really true, and possibly unrelated. So I just want to plant that seed in your mind. Since you went to medical school, they probably talked to you about molecular mechanisms of insulin resistance and the fact that adipocytes are important. Well, there's a whole other list of things that have come into play, some at the cellular level, some at the systems level. One of the most exciting ones is this notion that the gut microbiota can contribute to fatty liver. That's quite clear. That innate immune receptors in the liver can get triggered and cause insulin resistance because of a small, low-level flux of lipopolysaccharide and other bacterial products. The gut microbiota also can cause a decreased secretion of VLDL, leading in part to fatty liver. So there's a lot of work to do, is what I'm telling you. Now, here's one you may not have thought about. Your circadian rhythm is extremely important in determining the weight set point. There's a beautiful paper about a year ago taking genetically identical mice and letting them eat at the all-you-can-eat cafe. This guy gets to eat the delicious chow 24/7, unrestricted. And guess what? He gets fat, no doubt. But if you give this guy restricted, limited hours of feeding, he does not get obese. And even better, you can chalk up his diet and make it like the double-double at In-N-Out Burger. You make it a much richer diet, and he still won't get fat. This demonstrates to you that rhythm and timing have a lot to do with it. There was also an article in the New England Journal of Medicine showing that CPAP actually leads to a modest weight loss, about 5 kilograms. So sleep hygiene is extraordinarily important. And it's been known for 30 years that if you ablate the pineal gland in rodents, within a year they develop obesity and diabetes. So all of this is evidence telling you that the circadian rhythm is extremely important. Glitazones, pioglitazone, rosiglitazone, are in clinical use. You've heard a lot about them. This is a complicated molecular slide, but the teaching point is this. The target of glitazones really is not the liver. That's a secondary effect. The target of glitazones is this receptor called PPAR-gamma, which is predominantly in adipose tissue. So when you give a patient a glitazone, they gain 5 to 10 kilos, which is the expected effect. If you gave them, say, insulin, they gain weight too. But that may be good weight gain, because that's what insulin's supposed to do. It's supposed to dispose of sugar from the bloodstream, and it's supposed to store fat in the periphery. So these drugs mimic the action of insulin by activating PPAR-gamma. Secondarily, they have beneficial effects on all these other pathways. But I want you to know that because even most hepatologists don't know this, and there's a lot of scientific literature suggesting that it's PPAR-gamma here in the liver that's really being targeted, but it's not actually present in significant amounts there. Moving on to the genetics of fatty liver disease. In the last decade, there are probably 2 good examples of genes that have been implicated by large genome-wide studies. This one came out from Helen Hobbs' group in Dallas from the Texas Heart Study. They looked at fatty liver on MRI in a bunch of patients, and then they genotyped them all. And it turns out in this gene, PNPLA3, which is actually related to a potato lipase. So don't think you're too important because we have genes that are actually related to things in potatoes as well, all right? We're not that special. This particular gene, if you happen to have a C and a C on both copies for the alleles, your risk of fatty liver is quite low, irrespective of your ethnicity, self-defined ethnicity. But if you happen to have two Gs and you happen to be Hispanic, you have a much higher rate of fatty liver. And it's actually been shown that this gene tracks with cancer from fatty liver, fibrosis from fatty liver, and its mechanisms are being explored. The same is true for a gene related to cholesterol metabolism, the apolipoprotein C3, which we don't really clinically measure regularly. Turns out variation in this gene in Indian men from India predicts NAFLD, both hypertriglyceridemia in the serum and liver triglyceride content. So these things fall out of large genome-wide association studies, which are very difficult to do and very costly. So a systematic approach to finding all the genes that influence fatty liver and liver fibrosis really needs to be done, which is one of the things that my lab does here at UCLA. And the way we do it is, instead of doing genome-wide association studies on humans, we do it on mice, because you can get lots of genetically distinct strains of mice. You can control for their genetics. You can control for their environment. The equivalent in humans would be like taking a group of Okinawan Japanese and asking them to breed, say, with Icelanders, who are also genetically homogeneous, have them interbreed and have their children interbreed for several generations. Not going to happen, right? But you can make mice do that, and you can control the light and the food and everything else in the environment. And because we have 100 strains of genetically distinct mice, we are able to detect subtle influences that GWAS can't identify, i.e. genes that only may affect fatty liver 5 or 10%. So we're currently, processing this data now from two different experiments, one where the mice have been fed a high-fat diet, and one where we've induced liver fibrosis using a classic toxin. So stay tuned. All right, so treatment of NAFLD-NASH, which is probably all on your mind. This is might be a hard-to-read slide, so you have a printout. There's a lot of things, and this is not a complete list by any means. In fact, some of them have had a line drawn through. Sibutramine has been pulled off the market. There's a couple of new faces here. I'll speak about them in a little bit. But my major emphasis is to really talk about the 2 stars and the 1 stars. And I would put it to you, if you think about it, the reason I put 2 stars on them is because these are therapies that are actually directed at the problem. Everything else was really designed for some other purpose. Ursodiol was not designed for fatty liver disease, but it's been tried in it. Metformin was designed for diabetes, but it just doesn't work that well for fatty liver. So here's a list of what I think are the important clinical trials over the last now 11 years, looking at glitazones, rosiglitazone or pioglitazone, plus or minus the addition of vitamin E, metformin, losartan, a few other things. And you can see that they were short, they were lowish dose, and then we got up to 2010, and Arun Sanyal's group did the Beaven's trial for pioglitazone and vitamin E and non-alcoholic steatohepatitis. That's the fancy acronym. And guess what? Ooh, we got improvement histologically in these markers, but nothing in fibrosis. It's not better than a placebo. And follow-up studies in pediatric trials, again, showed actually no benefit. So the longest trial in human fatty liver disease and NASH is 24 months. So what are the issues with glitazones? Glitazones improve liver histology, but not fibrosis. Do patients care about that? No. Do you care about that? I don't, actually. I don't care that the pathologic findings are slightly improved. I care about the fibrosis. How long are you going to treat them with the glitazone? There's a potential risk for bladder cancer that's currently being litigated around the country. There's reportedly a 22% increased risk in developing bladder cancer in men who've been on the drug for at least 5 years. What about treating a non-diabetic with TZDs? Turns out there was pretty good effect for non-diabetics, but are you going to use a diabetes drug that gives them 5 to 10 pounds of weight gain for 50 years? That's not going to be very popular. And of course, you've heard a lot of press about the weight gain, the problems with people with heart disease, and potential loss of bone density. What I want you to take home is the idea that not all glitazones are equal. Some of them have very different abilities to lower blood sugar, and there are some partial ones that are in development that you're going to see come on the market probably quite soon. But hey, my patients all take vitamin E. That's cool, right? We can do that. That's okay. Well, no. I'm going to give it a modified no, right? So 34,000 people, vitamin E or selenium, or the two together, or a placebo. 8,000 guys in each arm for prostate cancer prevention. And it was a definitive trial, right? It's definitive. Except vitamin E results in more prostate cancer, not less. The vitamin E line is the top one. And you don't see a difference until you get out to about 3 years. So the longest trial in human fatty liver disease is 2. So what do I tell my patients who are 50? Am I going to keep you on vitamin E for the next 15 years when the risk of bladder cancer or prostate cancer is going up? So that's a little frightening. But that's an individualized discussion you need to have with the patient. There are other risks. There have been at least 2 large meta-analyses, one from 2005 saying more than 400 IUs per day, and the fatty liver dose is actually 800 IUs a day, may increase all-cause mortality and should be avoided. The cardiologists told us that back in the 80s and early 90s. They used it in atherosclerotic disease, and it killed people. So vitamin E was also tested in stroke prevention. 118,000 people. When are you going to see a trial like that again? You won't. There was no difference overall in stroke prevention, except when you do the secondary analysis and see a 21% increase in hemorrhagic stroke and a 20% decrease in ischemic stroke. But you probably, if you had to choose between the two, you'd probably take the ischemic stroke over the hemorrhagic one. Indiscriminate use of vitamin E supplements should be avoided, is the concurrent conclusion there. What about weight loss in a pill? I don't know about you, but every copy of my New England Journal of Medicine comes with an ad from Qsymia. Okay? There's one called Contrave, which is bupropion and naltrexone, that is getting a second life. They're going to try it again after they've convinced the FDA that it's not going to kill people from heart attacks. Qsymia is phentermine, yes, the fen of fen, and topiramate, which is an anti-epileptic drug. And then there's Belviq, which is a serotonin receptor agonist. And that's the percent weight loss you get. Okay? And by the way, Qsymia is basically speed. So speed's a pretty good weight loss drug. We know that. Okay? These two require lots of paperwork and a risk reduction approach that's required by the FDA. The fact that medical therapies don't work for NASH is shown right here. This is a New England Journal trial comparing 2 types of gastric bypass, weight loss surgery, with the medical one. And look, after a year, medicines don't, in fact, this curve actually starts to go back up by 2 years. That's also now known. So medicines really are not effective. Gastric bypass is, for reasons that remain incompletely known. And it's not just reduction of the size of the gastric pouch. And that's one of the things my lab and others here are interested in studying. The outcomes really should give you pause. If you thought, they just have a little fatty liver, I'm not going to worry about it. Start with this. 300 million people in the US. Conservative estimates of NAFLD and NASH give you at least 17 million people with NASH. And if you look at autopsy series, the absolute minimum number is 1.1%. If you happen to be a middle-aged white Texan vet, you've got at least a 1 in 8 to 1 in 4 chance that you have NASH. And so people spend a lot of time wringing their hands about what's the true population estimate. It's probably 5%. Okay? And based on the likelihood that you're going to get cirrhosis, liver-related death, or HCC, hepatocellular carcinoma, you're talking about huge numbers of people. There are only 6,000 liver transplants done in the country every year. So this is going to dwarf. Hep C is going away. I think you'll be hearing that shortly, but NASH isn't going anywhere. Even more scary is that the dogma that you need cirrhosis to get hepatocellular carcinoma is not necessarily true. We're finding people with just advanced stage fibrosis who spontaneously develop HCCs. And it's probably got to do with the biology of the lipids and the fats. So I am actually screening people with stage 3 fibrosis, not overtly cirrhotic, but just shy of cirrhotic. I'm screening them for hepatocellular carcinoma. Why? Because we can screen. There is ultrasound or MRI is pretty good, and if I find something, we actually can do something about it. We have good interventional techniques to take care of liver cancer because we're not going to be able to transplant all those people. And you can see here that across the last decade, NASH is the only thing that's increasing in terms of the number of liver transplants. It will probably soon be the number one cause. So managing NAFLD, how do you do this in an internal medicine or primary care setting? Some of the cliche stuff is still true. It's still true because it's the right thing to do and it's effective if you can maintain it. It's just difficult to get people to exercise. It's difficult to encourage weight loss. But it's like smoking. If you don't tell, just because you have a bunch of patients who used to smoke, did you stop telling them to stop smoking? No, you don't just give up. It's the same thing with weight loss. You have to encourage exercise and weight loss. I recommend talking with them first about maximizing sleep hygiene. You should see the looks on their faces when the first thing you do is you write a prescription for 8 hours of uninterrupted sleep, which means no TV in bed, no computers in bed, no reading in bed. There's 2 things that the bed is for, and one of them is sleeping, okay? So I've written prescriptions for that, and they're like, wow, my doctor didn't tell me to exercise. And I will tell them that, but not at the first visit, okay? Optimizing blood glucose. I think metformin is actually a pretty good drug. There's evidence that it can prevent certain types of cancer too. We love statins, okay? There's been a lot of bad press about statins, and that was an idiosyncratic reaction of the first one, or one of the first ones, Baycol. Treat that dyslipidemia, treat that blood sugar, and think about HCC surveillance in advanced fibrosis and certainly in cirrhosis. Individualized therapies, I would not go running around. I certainly don't give TZDs to everybody. I tend to favor giving them to diabetics if they'll take them. The vitamin E discussion is a real wing dinger when I show them that picture of the prostate cancer and the stroke data. But if somebody's close to cirrhosis, you could make an argument, I'm going to try you on this for a couple of years and see if we can slow things down. It's not a bad idea. But I think you should strongly consider bariatric surgery if the BMI is greater than 35 and they're not cirrhotic. That is a major, major intervention that works. So in summary, the pathogenesis of fatty liver, if you think about it, relates to a bunch of stuff outside the liver. The weight, we don't know what causes the weight set point, how it's determined. We know that exercise influences it, sleep, the circadian rhythm, and the microbiota. There's emerging genetics in NASH. We're behind the times compared to the cardiologists and various other fields. There are no good medical therapies for NASH, but bariatric surgery is for the right candidate. And I show my hero Homer Simpson here because what I do not recommend is that if your BMI is 32 that you go out and overeat to the point that your BMI is now 36. That is not a good suggestion, which is exactly what Homer did because he got disability, he got off of work, and then he found he couldn't move and do other stuff. But it's a little bit of a wake-up call. Fatty liver is not necessarily benign. There are a lot of people who have fat in their liver and have normal liver function tests and will probably never suffer anything from it. But the outcomes of NASH, inflammatory fat, are really ominous. That's a plug for our program studying obesity and metabolic health. And I better shut up before Tricia comes up here and pulls me off the stage. I see her walking down here. So thank you very much for your attention. I look forward to your questions.